Hit record. When we look at a patient case, it's all about filtering out what is pertinent information and what isn't. And part of this comes down to being able to understand it. It's easy for exams like this where you know what the topics are going to be about. Much harder on larger exams, like a final or something like that, where the number of topics is much, much bigger. So, what lecture topic are we probably talking about here? Are we talking about anemia, AKI, hepatology, AKI? Yeah. How do we know it's AKI? Because we're talking primarily about urine, right? Where the big problem is that he's only urinating 20 mLs of urine, right? So, how would we classify 20 mLs of urine? What would that be considered? Really low, right? What's the vocab term that we use to describe this? Anuria. So on the exam, you could be asked, here's a patient case. How would you describe his urine flow? And it would say non-oliguric, oliguric, anuric, maybe another one. And you would have to be able to decipher that. So a patient case has a lot of different information that they can ask about, right? Why would we care that he has a catheter and that it flushes easily and there's no obstruction? What does that tell us generally? Yeah. So we determined that we're talking about AKI here. So there's three kinds of AKI. And the fact that there's no obstruction and that there's good flow means that we're not talking about post. So we could either have pre-renal or intrarenal. What is the primary way we differentiate pre-renal versus intrarenal? What values should we be looking at? Exactly. The BUN to serum creatinine ratio. Also, did she go over the whole thing about don't call it bun? Please don't call it bun. Oh, yes, this is BUN. Please do not call this bun. Doctors will yell at you. In fact, a resident on one of my rotations called it bun in front of the entire team at rounds, and they made him walk away because it's not bun, it's BUN. You can't get all the way through medicine, start practicing, and start calling things by the wrong name. It was super embarrassing, super, super embarrassing. So for pre-renal, what should be the BUN serum creatinine ratio? What should we expect? Over 20, right? Versus intrarenal, we expect it to be somewhere below 10, around 10, 10 to 15, definitely below 20, right? So we can take the BUN 30 and we can divide that by 1.3. And this gives us post is under 10. I'm not sure. I've never really thought that the BUN serum creatinine ratio is really pertinent for post, but I could be wrong. I'd have to double check. So we have a ratio of about 23. 5-1 is rhabdo. Yeah. So a ratio of 23 tells us
He's
we're
going over the problems he gave us.
dealing
Yeah.
with pre-renal, right? If we're talking about pre-renal, what are some causes of pre-renal? What's the overall issue here? Hypovolemia. Exactly. Hypovolemia. So for whatever reason, there is not enough blood getting to the kidney, either because there is physically blood loss or that the blood volume has decreased. So this person just had a proctocolectomy. So he just had a portion of his the colon removed as part of a treatment for ulcerative colitis. So what is the possible etiologies, possible causes that could be happening right now? You have a surgery. What could have happened during the surgery? Blood loss, right? Maybe he had major bleeding. Malpractice, maybe. The other one is shock, right? Maybe he has such low blood pressure because the body is responding to the trauma of the surgery. And if we look, what's his blood pressure? Normal, hypotension, or hypertension? Yeah, it's lowish, right? It's not super low, but it's definitely lower. So this all together kind of gives us an idea. Okay, we're dealing with pre-renal. It's just called the BUN serum creatinine ratio, or the I think it's called the BSC. Sometimes they yeah, it doesn't have like a name to it. So we know that the issue right now is that he doesn't have enough volume in the blood. So what do you think? What are some things we can get rid of immediately? What do we know is the wrong answers? Right. Probably don't need to start an antibiotic, right? Exactly. Get rid of A. Giving furosemide, a diuretic, that is going to cause you to lose more fluid, right? Do we really want to just start removing fluid from him? No, it would be a terrible idea. F would be a suprapubic catheter. If you don't know, is you punch a hole directly into the bladder, you bypass the urethra. And so that way, if there's an obstruction in the urethra, like a really, really big prostate, then it's a helpful way. But we know that the catheter flushes easy and there's no obstruction. So there's no reason to put another catheter in him, right? What else? Do we need to open him back up for and see what's going on inside of his body? No, that would be the wrong choice, right? Tamsulosin. What is tamsulosin used for? What is its indication? Benign prostatic hyperplasia, which would be post-renal, right? So we know this is pre-renal. And so the question comes down to um, if you what kind of AKI would seeing what the kidney look like be most helpful? Pre-renal or intrarenal? Intra, right? If we're going to take imaging, we want to see damage. And that damage would be because we have tissue necrosis or inflammation, something like that. So the answer here is give fluids. Remember how I beat that into all of you? For the love of God, give them fluids. Fluids, fluids, fluids. Never wrong to give fluids to AKI patients, right? Any questions about this case? Was this helpful to go through this? Yes. So the reason why it's pre-renal is that we know it's not post-renal because he doesn't have any obstruction to the flow, right? So in order to differentiate between pre-renal and intrarenal, we need to look at the BUN serum creatinine ratio. So if the ratio is, and literally what we do is we take 30, the BUN of 30, and divide it by the serum creatinine of 1.3. And that gives us a value of 23. And then that is greater than 20. So we know that we have a pre-renal issue. Does that answer your question? Okay. Sweet. Sweet, sweet, sweet. So this hint was just talking about giving you the hint about the serum creatinine ratio. All right. 48-year-old woman brought to the ED by police because she's confused and agitated. No, I'm giving you guys time to go through the case. Just another minute to come up with an idea. 30 more seconds. All right. What do we think? What do we think the answer is here? A, folate deficiency, maybe B12, potentially. A, E. So it looks like none of us think it's that she's just drunk. None of us think that she overdosed on vitamin E, which is very possible, right? Vitamin E. Um, Vitamin E is not water soluble, so if you take too much vitamin E, it can, cause that issue. Vitamin B1 you'll learn about this next year in alcohol dependency. Uh, Whenever we have a chronic alcoholism, B1 deficiency is always something we worry about because it can lead to irreversible encephalopathy called Wernicke encephalopathy. Um, so, yes, tough disease. So let's take a look at what's going on here. So we know that she's confused and she's agitated. So right off the bat, what organ system is being affected by whatever disease state that she's in? Yeah, CNS, right? We have CNS involvement right from the beginning. We see that she has peptic ulcer disease and that she treated it with omeprazole. Um, what uh what vitamins do we know are affected by the use of antacids? So we have folate, we have B12, and we have iron. So how about Tums? Who's affected by Tums? Iron, right? Why iron? Because of the calcium component in Tums. How about PPIs like omeprazole or pantoprazole, lansoprazole? Who's affected by PPIs? B12, 100%. Anyone else? Exactly. Iron. Yeah. Iron needs an acidic environment in order to be absorbed, which is why we tell people drink it with juice, take it with some vitamin C. And then what about H2 receptor antagonists like famotidine, Pepsid? B12 and iron. Iron does not do well in basic environments. It needs an acidic stomach. So right off the bat, if you're taking omeprazole daily, your iron intake is going to be reduced. Your B12 intake is also going to take a hit, specifically because PPIs and proton pump and the histamine receptor antagonists, they prevent B12 absorption. So right off the bat, we know that probably what's not happening here is folate deficiency, right? Uh, we see that she's alcoholic. Neurological exam shows nystagmus, meaning she has cross eyes. Her balance is way off, and she has a really low hemoglobin. So, what does having a low hemoglobin tell us immediately? What can we diagnose her with if you have a low hemoglobin? Anemia. Exactly. This is the requirement for, oh my God, we need to treat your anemia immediately. We need to figure out what is going on. Homocysteine levels are elevated. Methylmalonic acid levels are within normal limits. And so this is a pretty classical presentation of vitamin B12 deficiency. B12 is all about CNS involvement. Tons and tons of CNS issues. Tingly hands, not being able to balance. Yes, what's your question? Versus in folate deficiency, what uh, we're mostly going to find there is uh, wait, sorry, folate deficiency, lots of GI issues, tons of GI issues with folate deficiency. So nausea, vomiting, abdominal pain, different stuff like that. Um, I believe so. Yeah, methylmalonic acid is I think it can is normal or might even be low in vitamin B12. Um, very nice. Very nice. Um, in this patient, what would we expect the uh what would we expect the MCV to be? Much higher, right? Folate vitamin B12, megaloblastic anemia, macrocytic anemia. Very nice. I just realized that I did the wrong one. Yep. All right. Case number 3. 36-year-old woman. She is in the first 26 weeks of gestation. She comes to physician for a prenatal visit. So what do we know about her? She's pregnant. She has been craving ice and paper products like toilet paper for the past 2 months. She carries a cup of ice with her wherever she goes, and she chews on the ice. No medications, although I hope she should be on a prenatal. And we see that she has dry, scaly lips. They're red around the corners of her mouth. And that her uterus is normal. Yes, I was just looking at that. It should be uh it 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 shouldn't be A. It should be E. I was typing it up wrong. It's E for B12 because of the CNS involvement. Me eating a metal sign. So, what do we think could be the issue here? First of all, what do we think her diagnosis is probably going to be? People are saying B. Yeah, probably iron deficiency, anemia. And specifically, what symptom or what syndrome is she presenting with? What do we call this? Her behavior. Pica. Very nice. Often you find people they'll eat like clay or dirt, and one of the things you'll find is clay and dirt in their teeth and in their gums or under their tongue. And it's one of the main ways you'll end up seeing it. I put a picture in here in case people are curious about what the spoon shaped nails are like. They really are. They're pretty bad. But you know how slow your nails grow, right? So you have to be deficient for a pretty long time for this to happen. This is called colonychia. Colonychia. Not good, right? You can see this person was digging around in the dirt trying to get iron. Could you eat soup? I hadn't asked. Any questions about this one? Pretty clear, right, Pica? All right. So here you're going to choose the row that would associate with the lab values. 48-year-old man comes to the physician after a 2-week history of upper abdominal discomfort and yellowing of the eyes. Over the past 3 months, his appetite has decreased. He has become increasingly nauseous. He smells of alcohol when he enters the office. Started drinking 15 years ago, and he consumes a pint of liquor a day. Vital signs are within normal limits. He has mild scleral icterus and conjunctival pallor. So his eyes are kind of the white of his eyes is kind of dull. The it You're thinking of jaundice. It could be. I mean, icterus can. I actually don't. I can't remember if icterus is yellow or not. Yeah, it is yellow. So here's a good picture of it. Very, very, very yellow. This is pretty intense. So if he's mild icterus and conjunctival pallor, he's probably something similar to that. Like it's mildly yellow. All right. So results of his lab studies are most likely to show which of the following. What do we think? So they're saying alcoholic liver disease. Do we want to go through and talk about hepatology first before we answer this question? Maybe that'll be, yeah, let's do that. All right, let's talk about the liver. For pharmacists, the liver is probably one of the most important uh, organs in the body, and thankfully, it can take a huge hit. You can really ruin your liver for decades, and it will just keep chugging along. But eventually, you outpace your issue. When we talk about um, the liver, just like with the kidney, we can talk about acute kidney injury, which is AKI, but there's also chronic kidney disease, which is a slower process and is usually it's usually irreversible. Same thing with the liver. You can have an acute liver injury, or you can have a slower cirrhosis uh, going on. Generally, what we look at is the key point that we want to look at is the clinical presentation. The liver doesn't have any pain receptors, so there's no way of knowing if you're destroying your liver based off of pain. So you're mostly going to see non-specific symptoms. So in the beginning, you're getting things like fatigue, nausea and vomiting, maybe some confusion. None of these would immediately point you to the liver, but by the time that you're getting to the point where you're starting to show specific liver symptoms, we're talking about pretty late into the injury. Specifically, jaundice, dark urine, and peripheral edema, swelling in the legs, and bad enough it can go in the hands as well, usually in the legs. The only way you can really understand what is going on in the liver is by doing an ultrasound and a biopsy. That is the gold standard of care, an ultrasound and a liver biopsy. But we can look at the injury pattern in general through lab values. And the lab values are going to give us an idea of what is going on in terms of uh, the function of the liver and how it's degrading over time. There are three things that we can look at in terms of the injury. The first is with the liver cells specifically. The second, which I will leave yourself some room. I'm going to relabel them later. The second is about bile buildup. And the third is all about synthetic dysfunction. So like I said, we're going to talk about these other two, but I wanted to leave room. Synthetic dysfunction. Inside the liver cell, you have three main enzymes. You have your transaminases, specifically AST and ALT. And you have lactate dehydrogenase, or LDH. Usually, don't have to know that. Okay. Oh, great. All right. For both of the transaminases, the normal value is that they are not elevated, so that they're below 35. But it's really, really important to understand where they are stored. These are intracellular enzymes. So the only reason why we would be able to measure them in the blood is if we are killing hepatocytes, liver cells. They're dying and splitting open and spilling their enzymes into the blood. So if you have damage, that is going to increase your transaminases, and that would be the only reason why we can tell what's going on. AST is non-liver specific. Definitely was lying. Oh, about not having to memorize. AST is found in the liver. It's found in the heart, brain, kidney, lung, skin, tons of places, red blood cells, tons and tons and tons of places. ALT is mostly liver specific. It's found really only in the liver and to some extent in the muscle and kidney. So if we're really trying to figure out if there is damage to the liver cells, what is the transaminase that is most important? ALT. So when we look at how we are differentiating this issue, we are specifically going to want a rise in ALT because it is the main liver marker. What's important to know about the value of AST and ALT is that you can have really, really, really high levels. You can have levels like 300, 400, 500, but it's not necessarily about the level. It's about the ratio between them that we care about. Let me move this down so I have more room. So the level itself isn't nearly as important as the ratio between them. A AST ALT ratio of greater than 2 maybe I should do this in a different color. AST ALT ratio, if it's greater than 2, is indicative of alcoholic hepatitis, meaning that we have major inflammation and damage in the liver. What this is talking about is that alcohol has caused necrosis or literal cell death in the liver. A ratio greater than 1 indicates severe liver damage. So any elevation of the ratio, you have damage. A ratio of 2 or more is indicative of alcoholic hepatitis. What I will say here is that elevated levels are indicative of cirrhosis, which is mostly just inflammation. So your ratio is equal to 1. So your ALT, AST ratio is equal to 1, but they're elevated. So um, they are above 35. You have cirrhosis, maybe chronic hepatitis, something like that. Any questions about the AST ALT ratio? Uh, Gold standard, ultrasound and liver biopsy. Gold standard, ultrasound and liver biopsy. No problem. If you're wondering, here's a helpful trick. ALT is the liver specific enzyme, and it is the lower one of the ratio. That's how I memorized it. ALT is liver specific, and it is the lower value. All right, LDH. LDH is primarily going to rise due to liver injury. This the way to think about this is that it supports a liver diagnosis, but it doesn't definitively determine it. Uh, it just because you have high lactate doesn't necessarily mean that you have liver injury. It could be multiple different things. The reason for the elevation is because of a hypoxic environment. So we have low O2 due to poor perfusion. So something is preventing blood from nourishing the tissue, which is causing these cells to die. So essentially what's going on is that the cells are not getting oxygen. They can't go through aerobic respiration. So they're using a lot more lactate as their energy source, and that is creating this rise in LDH. So how do you use LDH in terms of a question? The way that they would phrase an LDH question is probably about you have a high AST ALT ratio and you have a high LDH. Would that be indicative of liver injury? Yes, 100%. Supports the diagnosis. If you have a normal AST ALT ratio but a high LDH, does that necessarily mean liver injury? No. It could be because of a different issue. Yes. Yeah, let me write it down. So an increased AST ALT ratio with and increased LDH, you have liver injury. But if you have a normal AST, ALT, and increased LDH, it may not be liver injury. Could be something else. If you ever need me to repeat, write something down, let me know. I can talk quickly, I know. I just get excited talking about liver injury. Bile buildup. One of the main functions of the liver is to process fats, cholesterol, all that good stuff. And what we see is that when there is a obstruction leading to bile back up into the liver, what we see is the liver trying to adjust to this increased bile mass, essentially. So we have some sort of injury occurring from this bile buildup. The reason why this happens, I think this is the way that it was explained to me, is that it's almost like you're putting gum in a factory. Like you're just gunking it up and it's just slowing everything down. It can't get rid of the waste it needs to get rid of. So you're just backing everything up. And so it starts to get pretty nasty pretty quickly. One of the main things that we look at in order to figure out if we have a bile issue equals increased alkaline phosphatase, ALP. So the normal range of alkaline phosphatase is 36 to 92. If you have a bile issue, your ALP is going to shoot right up. Even a slight backup of bile will cause an increase in ALP. It's very, very sensitive. Slight backup. Rise in ALP. ALP has a very long half-life. So it has a very, very long half-life and it is released slowly. So what does this mean? Is that it takes time to rise. Takes time to rise, but it takes time to get rid of. So if someone, let's say, they all of a sudden they develop a gallstone, you're not going to see a rise in ALP immediately. It's going to take a little bit of time for it to rise, but once it does, it's going to hang around for a long, long, long time. The problem is that ALP exists in the bone and the liver. So if you ALP is in the bone and liver. So an increased ALP could be a liver issue or a bone issue. It's non-specific. We don't know. So what that means is we need to use another enzyme which will also rise due to bile in order to confirm what the source of all this ALP is. And that's where gamma glutamyl transferase comes in. So GGT, which has a value of 0 to 30, rises, how do I want to explain this? It's only found in the liver, the gallbladder, really the biliary tract, I guess, and the pancreas. So where is it not found? Bone. So if you have increased ALP with increased GGT, this is a confirmation of bile issues. Whereas if you have an increased ALP, but you have normal GGT, it could be bone. So maybe someone broke their bone. Maybe they broke a femur. Maybe they're pregnant, right? Because pregnant people are growing bones. Or maybe they're a child and they're growing and elongating all of their bones. So GGT is used to confirm an ALP rise. Any questions about this? All right. One of the other important uh, kind of values to look at in terms of cholestasis or bile backup is bilirubin. Bilirubin, actually, this is a good question for you guys. Do you guys remember where bilirubin comes from? Very nice. It's the product of red blood cell breakdown. So the liver is responsible for breaking down the sorry, no. The liver is responsible for taking this bilirubin and conjugating it with albumin. So you get this bilirubin albumin uh, complex. And what should happen is that the complex is immediately dumped into the bile. Delta bilirubin, exactly. So as soon as the conjugate is made, it's dumped right into the bile, put into the feces, right? If you have a backup of bile, you are going to see a rise in bilirubin. So a rise in bilirubin levels is reflective of a backup of bile. Let me put it this way. Increased conjugated bilirubin. We refer to this as hyperbilirubinemia. which is going to be the name of Sarah's first child, which is where you get the idea of jaundice coming from. Bilirubin is in the blood you would be testing for. Now, leave some space here because we are going to talk about what happens if you have an increase in unconjugated bilirubin. So leave some space, but we need to talk about something else first. All right. Synthetic function. The liver is responsible for making a ton of important proteins, vitamins, tons of different stuff for the body. Has a ton and ton of different roles, which is why, say, grams. Yes. Yeah, it's because bilirubin is a huge molecule. Huge molecule. Like albumin. Um, Dr. Grams. Oh, she's the one that taught this lecture, right? Yeah. Ugh, awful. Awful. First up, let's talk about albumin. Albumin has a level 3.5 to 5, and it makes up 60% of all total protein. What's the function of albumin? What does albumin do? Yeah, it's a transport molecule. It's transporting lipophilic molecules in our blood, which of course is made up of mostly water. It is also maintaining osmotic pressure. What this is essentially talking about is that the fact that we have albumin in the albumin in the blood is what keeps the blood pressurized. So the way to kind of think about it is that albumin is kind of like the fizzy bubbles in your soda. If you want fizzy soda, you need albumin. If you want pressurized blood in order to flow to different places, you're going to need albumin. One of the things that ends up happening is that if you have low albumin, this leads to pretty quick liver dysfunction. And can anyone tell me why? Why is this specifically going to cause an issue? Well, albumin is made by the liver, right? So if there's already a problem with the liver, you're going to have low albumin. But then why would it cause this positive feedback loop? Yeah, you're on the right track with the toxicity. From what though? Exactly. It carries bilirubin. So going back up to this idea about unconjugated bilirubin, if you have low albumin levels, then you are not conjugating your bilirubin. And so is unconjugated bilirubin indicative of obstructive jaundice, obstructive hepatitis, or synthetic dysfunction? Is this because of a block. What was the question? If you have an increase in unconjugated bilirubin, is that because you have some sort of buildup of bile, or is it because of a synthetic dysfunction? The synthetic ability of the liver is decreased. Yeah, it's synthetic. Why? Your liver, something happens to the liver. You drink a ton of alcohol. Suddenly that triggers the hepatocytes to stop making albumin. All of a sudden, no more albumin means that you're not conjugating your bilirubin. Now it's just hanging around the blood, and then you get jaundice. So, and then as as the cells stop making bilirubin, the bilirubin isn't able to conjugate and then get cleared out of the body, which is going to build up bile, which is then going to further toxicify, which is not a word, further cause issues um, in the liver. So huge, huge issue. Indicative of a synthetic issue, not obstruction. A couple of other things that we should note. I want like 6,000. Let's try that. Oop. There we go. We're going to talk about causes in a second. We'll make it a lot more clear. But what you put is in too much bilirubin, jaundice. You need to have high bilirubin to get jaundice. If you have low albumin, that can cause your bilirubin to rise. Your unconjugated bilirubin. So it depends on which value you're talking about. We'll talk about it. I promise I will make it less confusing. Other thing that we should talk about is coagulation factors. The liver is responsible for making a ton of coag factors. You'll talk more about this specifically when you get into coagulation for I think it's exam 3, maybe. But really what's important here is that we have 3 values. Why did this suddenly become all fuzzy? What? What? Fuzzy? I don't know. I'll have to do it over here. The first one is prothrombin time, or PT. The next one is your activated partial thromboplastin time, APTT. And the third one is the INR. Really, all you need to know is that if you have an increase in any of them, it's indicative of bleeding. Increased risk of bleeding. Oops. Give me 1 second. Sorry. I have a patient calling. I have a patient. She wants to tell me all about her stool. She's very excited. Well, she's been constipated for like 6 weeks, so we're gonna figure out if it's worked. Yeah, not good. She's also 92, so we don't we don't want this. All right. So just to reiterate, just to really make this clear and to put it all in perspective. If you have liver direct liver cell injury, we are going to see a rise in the AST, ALT, and a rise in LDH. Oop, what just happened? There we go. What is going to cause this direct cell injury? What do we think? What as a pharmacist are we always worried about? We're not always worried about alcohol, but drugs, right? So we shouldn't always be worried about alcohol, but drugs. So specifically hepatotoxic drugs. What is the big one that you all have in your apartments or houses that is very liver toxic? It's specifically in your medicine cabinet. Acetaminophen. Very, very liver toxic, right? You guys have said it a couple of times, but alcohol is definitely one of them. The last one is viruses, viral hepatitis. Definitely viral hepatitis. Really, no, none of that is really important. Did she talk about treatments for you guys? Like, did she talk about lactulose and all that stuff, or did she just describe these issues? Two drugs? Which two drugs? Lactulose and like N-acetylcysteine? Lactulose and rifaximin. Oh. Yes. Okay. Yes. We'll talk about those. So direct liver cell injury, what is causing it? Hepatotoxic drugs, alcohol, or a viral illness. So herpes, Epstein-Barr, uh, cytomegalovirus, hepatitis A, B, E, all of those good ones. Cholestatic injury. This is the fancy name for what we talked about bile buildup. What are we going to see in cholestatic injury? We are going to see increased ALP and increased GGT. What would be some causes of cholestatic injury? Oh, and increased conjugated bilirubin. What would be some causes of cholestatic injury?
Alcohol?
Yeah, alcohol, right? So what we're talking about here is probably cholelithiasis or gallstones. Our our good old friend gallstones. Um, Gallstones are going to prevent the bile from uh, what's the best way of explaining it? They're going to prevent the oh, what is this called? Cholangitis? I can't remember the vocab terms. It's been so long. Um, da, 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 I'm just trying to find the right wording so I'm not telling you the wrong thing. Um, One second. There we go. Gallstones. So, usually this is from a very, very fatty diet. So people who eat a ton of processed fatty food, their gallbladder is not able to process that fat as much, and it can create these stones, which can then back up the liver. Another big issue that can end up happening with that causes this bile buildup is um, hemolytic anemia. Usually this is autoimmune or it's caused by a drug, but what's essentially happening here is that you have increased red blood cell destruction. Why would increasing red blood cell destruction cause an issue for the liver? Increased bilirubin, right? If you're increasing the rate that you are destroying red blood cells, then you are going to dump more and more of it into the bile, but the bile can only handle so much, so it could back up, and then you end up with cholelithiasis or cholestatic uh, cholestasis. I don't think you have to know any of these words. It's really only in cholestatic injury that we see jaundice. Okay, you need to have a increased bilirubin level in order to have jaundice. No increased bilirubin, no jaundice. The last one that we talked about is synthetic uh, dysfunction. So we're going to see decreased albumin and then increased prothrombin time, activated PTT, and increased INR. All three of them. Um, what is mostly going to be causing this synthetic dysfunction. Uh, it would probably be similar to up here. It would be drugs, alcohol, and viral. Unless if you're going to talk about chronic liver disease, which is a slower process. Any questions about this breakdown? Was this helpful? Did this kind of clear things up for people to go through this? Okay, great, 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 great. All right, let's talk about those two drugs, and then we will go back to our patient cases. Whoops. All right. There is not a lot of treatment that we can do for any of these issues. Okay. Like we said, the signs and symptoms of a liver disease are pretty non-specific. But the one that we care about a lot is encephalopathy. Specifically, encephalopathy caused by the liver, called hepatic encephalopathy. What encephalopathy is we have a brain dysfunction due to liver dysfunction. Due to liver dysfunction. Usually this is because we have a buildup of waste products. Let's put this in the right order. So someone ends up with cirrhosis. So we have some sort of liver scarring. So we have, tissue starts to die. This is going to decrease the liver metabolism. So things are not being cleared the way that we expect. And so what ends up happening is we have an increase of neurotoxic metabolites. Exactly. Specifically, ammonia. What ends up happening is that this excess ammonia is going to cause swelling in the brain, which is what the encephalopathy is talking about, swelling in the brain. This is going to increase cranial pressure. And what this happens is you have brain deterioration. Other things that happen from high ammonia. So if you have high NH4, and this is more just so that way you can see just how dangerous this is. If you have high NH4, you end up with hypokalemia. You also end up with very, very acidic blood. Very, very, very acidic blood. No, basic blood. Very basic blood. which again, not good. You're messing with the electroneutrality of the brain, then you're messing with the pH of the brain. Not good at all. So when we talk about liver, the general approach is twofold. One, avoid further insult. So we're going to prevent the damage from continuing. And so as pharmacists, what just like we said in intrarenal AKI, stop the drug. If you're giving a hepatotoxic drug, get rid of it. Do not give it to them. This could also mean that if you have if it's caused by gallstones, get rid of the gallstones. Ultimately, the only way to treat this issue is with a liver transplant. The only way we can cure this issue is with a liver transplant. Everything else is just to manage symptoms and prevent progression. So we have two drugs that we can choose from. The first is lactulose, which is it's actually it's a laxative, but it is first line. What is happening with lactulose is that it is preventing ammonia absorption in the gut. So we're essentially trying to prevent the diet from having any more ammonia than necessary. And the mechanism is kind of cool, and I just want to show you what's happening here, because will explain the other drug that we're going to talk about. So lactulose, which is a type of sugar, is converted to lactic acid by the bacteria in our gut. By gut bacteria. You're making lactic acid. It's an acid, right? So you're going to acidify the gut. This is going to convert dietary ammonia to ammonium, NH4, which prevents absorption. Right? We know that ionic drugs are not able to be absorbed into the body. So by acidifying the gut, we're preventing ammonium from being absorbed. Kind of cool, right? Taking advantage of the gut bacteria. The other way that we can accomplish this, and it works pretty well for people who are not responding to lactulose, is the antibiotic rifaximin. It's an antibiotic. This is an off-label use, but it's fairly common off-label use. And what this is doing is that it's killing ammonia producing bacteria in the gut. So instead of acidifying the ammonia to prevent absorption, we're just outright killing the bacteria to prevent it. What's important to know is that this should be used in combo with lactulose. You really shouldn't just be doing rifaximin alone. You really should be doing both at the same time. Any questions about this? All right. Shall we go back to our patient cases? Was this helpful to walk through this, by the way? Okay. All right. Good. I never know because I can't see anyone. So I never know if like I'm just drolling on and people are furiously scribbling, trying to get it all down. So if I talk too fast, please let me know. Yeah. Thank God it's recorded, right? All right. Here we are. 48-year-old woman. She drinks a lot of alcohol. What what enzyme elevation issues should we see in this lady? Oh, sorry, it's a man, 48-year-old man. All right. What do we think? People are saying potentially D. Any other ideas? I would agree. So if we look at the ratio here of AST to ALT, we see that we have 150 over 65, which I'm not going to do the math, but is definitely over 2. 2.3. So this is a pretty clear indication that we have alcoholic disorder, right? And if you calculate all the other ratios, this would be less than 1. Here we would have equals 1. This would be less than 1. 200 divided by 15 is 13, which is just unbelievable. 13, if you had a value of 13, what is that probably indicative of? What organ is probably failing in C? Not everything. Everything but the liver, right? The liver is actually fine, right? Because what is the liver specific enzyme? AST or ALT? ALT, right? Which of these values is actually fine? This guy. This is fine. So what is this indicative of? Maybe they have a heart issue or a bone issue or a kidney issue or a lung issue, something else. Cancer, it could be, who knows? Well, that's a really good question. What are we comparing the 13 to? If we look at the values that we just talked about, we talked about greater than 2, greater than 1, or equal to 1, right? So the value of AST is and ALT is less than 35, but this ratio of 200 to 15 is just so astronomically higher than our ranges, right? Like 13 versus greater than 2, that is just unbelievable. So don't fall into the trap of just automatically creating the ratio, right? ALT is going to show us, is there a liver issue? And C is the only one where we really don't have a liver issue. Really nothing is going on. Um, do, do, do. Why include MCV? Why do we care about MCV? Which is 80 to 100. Yeah, right? We're talking about an alcoholic, right? Someone with pretty severe alcoholism. Alcoholism is going to decrease vitamin intake. So this is just a way to confirm that we're talking about, this is almost your confirmatory value, that we're talking about decreased vitamin intake due to alcoholism, right? So we know that what vitamins are they probably lacking in their diet? B12 or folate. We don't know which one. We don't know. Any questions about this problem? So if you come across a liver question, step 1, look at ALT. Step 2, find the ratio. Step 3, uh, look at the other enzymes. ALT will tell you if we have a liver issue. The ratio will tell you the severity of it. Are we talking about alcoholism? Are we talking about um, a very, very severe acute liver injury? Or is it something more mild, something more chronic that is going on? And then your other enzymes will kind of give you an idea of what the cause is potentially. Great, 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 great. Moving right along. 10-month-old boy is brought to the physician for a well child examination. He was born at term following an uncomplicated pregnancy and delivery. Medical history is unremarkable. His maternal uncle has alpha thalassemia, which is a kind of sickle cell disease. His immunizations are up to date. His diet consists exclusively of breast milk. He can walk on one hand held and can throw a small ball. Can pick up an object between his thumb and index finger. He can say mama and dada. Physical examination shows no abnormalities. Lab studies shown below. This shouldn't say which of the following, but what do you think is most likely causing these lab findings? So good. So we're identifying that it's some sort of anemia, right? Where, something's going on with the blood, right? So let's go value by value, right? Is his hemoglobin, babies are usually, well, what's the normal range for hemoglobin? I'll ask that first. 12 to 18-ish, right? He's a baby, so he's probably going to be on the low end, like 12 towards 12, right? I believe by the time you're getting to like a 1 year old, it's closer to like 12 to 13, something like that. But what we can say about him is that, does he have clinical anemia? Do we have to treat it? Yes. Yep. You have low hemoglobin, you have anemia. We have to treat it. No good. His MCV is low or high? Very low, right? 72. So what is this indicative of? A microcytic anemia, iron deficiency anemia. Exactly. So it's a good question. So which is most likely causing his lab findings? Iron deficiency anemia. Most likely is what's causing it. What would be the treatment? Give the mom iron, give mom iron. Yeah, you wouldn't want to give the baby iron because they wouldn't really handle it very, very well. This is actually a very common condition, iron deficiency anemia, in children that are exclusively milk drinkers. So breastfed or cow's milk, we often find iron deficiency because there's no iron in milk. There's no iron. So the way you would handle this is change the diet. Yeah. Do you have to know that for the exam? No. The exam question here would be, what is the diagnosis, right? What is going on? Iron deficiency anemia. That would be the question. But just so you know, if you ever have someone saying, "Oh, I only breastfeed my kid," you want to check that they're supplementing with iron. There are some baby iron formulations. Um, so you could. He's a 10-month-old. You could give some iron. He could deal with it. I think they're just gummies actually. Um, but a 68-year-old man is admitted to the ICU after abdominal aortic aneurysm repair. The patient has received 4 units of packed red blood cells during surgery. During the first 24 hours, he has only passed 200 mLs of urine. He has congestive heart failure and hypertension. He's currently on atenolol, enalapril, and spironolactone. He appears ill. He has normal temperature. He has an elevated pulse. His respirations are okay. And he has slightly low blood pressure. He has dry mucous membranes and flat neck veins. And everything else is fine. His serum creatinine is 2.0. His BUN is 48. But his creatinine on admission was 1.2 and his BUN was 18 initially. So what are we likely to find in this patient? So whenever we encounter an AKI problem, we know that there's 3 possibilities. We could be talking about pre, intra, and post. What can we get rid of right off the bat? What can we probably get? Probably get rid of post, right? We're probably not talking about post-renal. So what's the only way you can differentiate between pre and intra? The ratio. So right now his ratio is 48/2, which would be 24. So that is indicative of pre-renal. So if we have pre-renal, what could, yes, they're elevated. Yep. So originally they were 18/1.2. The uh what is the two what is the cause of pre-renal AKI? Hypovolemia, right? Is blood getting to the kidney? No. So if blood isn't getting to the kidney, is water going to be passed into the kidney? No. So we know he's not making urine. This is probably a complicated one to include. I probably shouldn't have included this. So if A is a good idea, you guys haven't really done enough with diuretics to really kind of understand the idea of osmolarity, but their blood isn't getting to the kidney. We're not being able to process any urine. Are we going to really worry about white blood cells in the urine? No. That would be indicative of a UTI, some sort of infection in the kidney or the bladder, something like that. Are we going to expect blood to be in the urine? What kind of AKI would we find blood in the urine? Or more likely to find it? What is the kind of AKI where the tissue is breaking down and ATN or just intrarenal, right? Because all of those are talking about, tissue death. And so if you're talking about tissue dying, you're likely to get some bleeding, right? So really in intrarenal, we might see some bleeding going on. And then same thing again, where are we going to get protein in the urine when the tissue is breaking down and dumping all of that excess stuff into the urine? So we expect to have low urine sodium because there's no blood being filtered. He's not producing any urine. Does that kind of sort of make sense? This is a pretty complicated one, I would say. This is probably one of the more complicated cases that I put in. So if you're able to kind of follow the explanation here, I'd say you're in good shape with this problem. What stage of AKI is he in? Exactly. There's no obstruction, so it's not post-renal. He's hypotensive. Regular is 120/80. So he's slightly hypotensive. Yeah. So how do we find the staging? Well, stage 1 is an increase of 0.3 or 1.5 to 1.9 times baseline. Stage 2 is 2 to 2.9, and stage 3 is above 3. So what we would do is we would divide 2 by 1.2, and I don't have a calculator. What would that be? Some amount. 1.2 divided by 1.2 gives us 1.6. We're going to talk about, well, that's his past medical history, hypertension, right? His past medical history is that he has hypertension. Yeah. Oh, yeah. You put that in your, yeah. So this is 1.6. So this is indicative of he has a 1.6 times increase from baseline, right? His baseline was 1.2. It's elevated to 2.0. So what is the increase from baseline? 1.6. So he's stage 1 AKI. Does that make sense how we found that staging? Any questions about that? Yeah. So the way that we stage AKI is we take the new serum creatinine and we take the baseline serum creatinine. Yeah. And we divide them and we get this multiplier of 1.6. So this means that his new serum creatinine is 1.6 times the baseline. 1.6 times the baseline. So that would fall into stage 1 staging. What about if I told you 6 months ago and 1 year ago, his serum creatinine was actually 0.7, right? So we go back into his profile, we find, oh, his baseline is actually 0.7. That's where he normally is. How would that change his staging? So we would take 2.0 divided by his baseline. We find that this would be an amount. 2 divided by 0.7, 2.8. So he would be stage 2 if we found out that was his baseline. Does that make sense? Does anybody have questions about that? All right. This would be a question you would get asked. Staging. All right. What is the treatment? What are we going to give him? So we found out he has hypovolemia. We need to give him something. There's 2 things we need to give. First one is fluids. And I'm going to point this out specifically. What is the issue with having heart failure? What happens if you have too much fluid? Edema, right? So what were the 2 conditions that can cause edema with excess fluid? One of them was heart failure, and the other one was pulmonary edema, right? So if you see a patient with congestive heart failure on the exam, you must give a diuretic like furosemide. You have to give fluids and you have to get that fluid out. Does that make sense? Any questions about that? You're all going, I have to remember it's heart failure. I have to remember heart failure. All right, we'll make this our last one, and then we'll there's 4 more for you guys to do on your own. And then I have to call that patient pack. 59-year-old man comes to the emergency department because of worsening nausea and reduced urine output for the past 3 days. Oh, do I want to? Yeah, we'll do that one. That's actually, it's a good one to talk through. Case 9. This one you guys should be able to do on your own based on our conversation yesterday. I'm just thinking about like which ones. This one you guys should be able to talk about. No, we'll go through case 12. This one is a little bit more complicated. 72-year-old man with type 2 diabetes is being evaluated 3 days after being hospitalized for acute abdominal pain in the left lower quadrant. He had contrast enhanced CT scan of the abdomen. After admission, confirmed a diagnosis of acute uncomplicated diverticulitis. Woof. His only medication was metformin. He is currently on bowel rest. His current medications are insulin, ketoprofen, and piperacillin tazobactam, which is a pretty intense antibiotic. Pip-tazo, big antibiotic. He has slight fever. He has normal respirations and some tenderness in his gut. And here is his labs. What do we notice what are some things we notice about these labs? Someone's saying CT scan. Apparently they're excited about the CT. So we see that we're given the BUN and serum creatinine, right? So what is his ratio right now? Somewhere around 11. So like you guys said, this would probably be intrarenal. So what are causes of intrarenal generally? What causes intrarenal issues? Drugs. Generally, what causes the issues? Drugs. What are the specific conditions? ATN, AIN. But what is, the overall issue going on? You have destruction of the kidney because of a drug, some sort of drug. So we have 3 kinds. We have ATN, AIN, and what's the other one? Oh fuck me, what's the other one? Obstruction, crystallization. Let's talk through the crystals first. What's the big one that we worry about with crystals? Oh, and rhabdo. Yeah, rhabdo would be another one. What's the 2 drugs, 3 drugs, drug crystallization. The Virs, yep. So all your antivirals, right? Acyclovir, Ivanaspvir, antivirals. Methotrexate, yep. MTX, methotrexate, and Bactrim. 3 big ones: antivirals, methotrexate, Bactrim. What about for rhabdo? What are we really worried about in rhabdomyolysis? What's the 2 big drugs? Muscle fatigue, yep. So exercise. And what's the big drug we worry about? Class of drugs. Statins. Exactly. All right. I'll walk you through the other two. For ATN, in terms of drugs, what we are worried about are antibiotics generally. There's a whole bunch that can cause direct nephrotoxicity. Anti-neoplastics or cancer drugs. Cisplatin, amphotericin B, which is an antifungal, and contrast dye. For interstitial nephritis, we have beta-lactams, which are types of penicillins, PCNs, and NSAIDs. So penicillin-based antibiotics and NSAIDs. And remember that AIN is an allergy. You have a hypersensitivity inside the kidney, causing it to swell shut. So I'm going to give you guys a hint here because you haven't gotten to these drugs. But ketoprofen is basically the same thing as ibuprofen. And piperacillin tazobactam is a penicillin-based antibiotic. So which disease state do we think he's in? We know it's intrarenal because we did the ratio. The ratio told us that it's around 11, intrarenal. So is it going to be ATN, AIN, crystallization, or rhabdo? ATN because of the antibiotics, potentially. Maybe contrast dyes. 3 days with he would have had 3 days of antibiotic. They would have just done the contrast dye 1 day. Good question about crystallization. Yep. You got everything, right? Right. Right. So the answer here is well, what do we think? What do we think? ATN or AIN or crystals? I think we can all agree that it's not rhabdo, right? Not rhabdo. ATN. I would agree ATN. Now let's talk about it. The reason why it's ATN here is because the biggest indication that it's ATN is contrast dye. Contrast dye in combination with intrarenal AKI almost certainly is because of the dye. It is so toxic that people are just not able to handle it at all. The other thing that we look at here is what's going on in the urine. What do we notice about the urine? We have casts, right? So really in ATN, we are seeing bits of tissue flying off and ending up in the urine. Are we really getting that when we're just swelling? Not really. What we are getting with ATN is when we have flecks of kidney tissue in our urine, causing it to turn muddy brown. Gross, right? The other thing that kind of clues us in here about an ATN etiology is if you remember when we talked about this yesterday, what is another non-drug cause of ATN? So we had drugs and there was another big one. Give you guys a second to flip back. Answer is infection, sepsis. So the fact that he already has an infection is another factor that's playing in here. That's probably uh, causing the issue. All right, we identified the cause. What's the treatment? What are we going to give him? Fluids. Get that shit out of him. Do we need to diurese him? Do we need to give Lasix? We're not told that he has heart failure or pulmonary edema, so it's not required. The what is the other important thing, especially if he has an infection? Make sure that the infection is going away, right? That it is clearing out of his system. No iron. Yeah. What if it turned out to be AIN? What's a drug that we could give if he had inflammation? What was one of the drugs we talked about for inflammation? Steroids, corticosteroids, prednisone, hydrocortisone, different stuff like that. All right. All right. There are 3, 11, 10, 9, and 8 for you guys, and 7 through 11 that you guys can do. Down below is all of the answers with explanations, different stuff like that. If anything's confusing, please let me know. Please let me know if this doesn't upload tonight. The other one, I just couldn't get it to work out. I did it again in the morning and it worked. I'm going to try not to have that happen again. If you have any questions, send me a message. My phone number is on the classroom. Go to
I just had a
people.
quick question real quick. Hold on,
Yes.
just before you go. So you said if there is heart failure, we give them Lasix furosemide.
Yes. Yep.
Okay. And that's for ATN, right?
For any kind of renal disease. So it
Okay.
doesn't matter what, if it's pre-renal, intrarenal, or post-renal. If they have heart failure, you have to give a diuretic. Have to give it.
All right. Thank you very much, Gabe.
No problem. All right, everyone. Good luck. I will check in the morning and see how things went. What time is it in the morning?
It's at
Two
2.
o'clock.
Oh, okay. All right. So you got some time in. So, do you think of anything? Send me a message. Bye, everyone.